Well, okay then. So the folks that are here today include Dr. Wozniak, Dr. Todd Haugen, Tim, myself, Craig, David, and Neil, and Christine. Dr. McCarthy had to go to another conference, and Lonnie Den also had another engagement. So that being said, Lonnie was supposed to give an update on the national action data for the year. I went ahead and made a brief presentation of that, so I'll bring that up. It's okay.
Changing the address.
Yeah. Okay. So, for those of you who don't know, the Action Registry originated via the Heart Association and has been co-opted more or less by the NCDR in collaboration with the Heart Association. There are a number of institutions that participate in it, but unfortunately it doesn't comprise the whole nation and all the providers of care for heart attack patients. So if you go to the CDC and the AHA websites and try to distill what the data are as they exist today, 635 Americans will have a new coronary event, which is an MI or heart-related death, and 300,000 will have a recurrent event. There are also a number of silent infarcts every year, so it comes up to about 735,000 events, of which probably about 500 are STEMIs. The average age is 65 for men and 72 basically for women. Interestingly, in this data set, 34% will die, which is just a little different than what you'll see in the Action Registry. And 15% who have a heart attack will die. So nationally, it's been reported that about 10% die. The mortality rate, as we said, is 15%. Patients almost always present beyond 2 hours after onset of symptoms. And the incidence of heart failure is about 20% over 5 years, so a tremendous toll. Fatal heart disease per 100,000 persons, interestingly, is increasing, and you can see at the bottom the distribution versus age and ethnicity. So a huge burden on care. This is the number of active Action Registry sites. A little over 1,000. In Texas, there's 137. If I remember correctly, there's approximately 150 STEMI receiving centers. And so a large number of the STEMI receiving centers are covered by Action in Texas at least. There's not much coverage of non-STEMI receiving centers by Action around the country. The good news is that the STEMI performance is at 96% of the registries in the 4 quarters of 2014. And all the other parameters are pretty good. The average age is a little younger than what was reported in the CDC data, and the other risk factors are pretty similar. In the STEMI population of just under 72,000 patients, most of them had ST elevation, and then a small minority had new left bundle branch block. Shock was present in almost 10% of patients. Pre-hospital cardiac arrest, 8%. I think that's not much different than what we're seeing, although maybe not. It represents a little less serious population than what many of us experience. Surprisingly to me, the average length of stay is 3 days. Given the kind of infarcts that we tend to get, which tend to be in shock or pre-hospital rest and so forth, the length of stay is a little longer than that. And in the action mortality rate, 6% mortality rate, which is lower than what's been reported by other agencies. Heart failure is about half, and shock is about half of what other people have reported. The reperfusion therapy now, Catherine, what does premier mean?
Where are you?
The top. Use a reperfusion.
It's just a level.
this-
It's just a level of entry into the action registry. You can have a basic set or a more robust set
Right.
of data.
So that's the premier. So it's a bigger.
They're entering all the data elements. You have a limited data set, and then you've got the Premier.
So it eliminates the hospitals that are just given partial data.
I see. Okay. Well, do you want to take this, Tim, since you know about the? I'd be happy to for somebody else to do it that really knows about it. Any rate, there no reperfusion occurs in a very, very, very small number of patients. There was a contraindication in 12%, which is interesting to me. I think that I don't really understand that. Primary PCI remains the mainstay of treatment. Fibrinolytics are only used in 4% of cases. And as we talked about last time, the data on pre-hospital fibrinolysis in terms of pre-transfer fibrinolysis followed by emergent PCI apparently has not been adopted at much of any level. This is very similar to what I think we're finding in Texas, and we're going to get a report on that in a minute, that if you go to a PCI center, you do pretty well, and you get the artery open in less than 90 minutes from showing up, which is about 180 minutes after onset of symptoms typically in 96% of patients. But if you go to an outside hospital and have to be transferred in, then you miss the onset of pain or the presentation to initial hospital to balloon up 70% of the time. And similarly, most people don't get fibrinolytics in a timely fashion either. So as we sort of talked about previously, the right side, I think, is where the sweet spot is for improved STEMI care. These are the door to balloon benchmarks for transfer in patients. First door to balloon, less than 90 minutes, 30% of the time. A little over half if you go up to 120 minutes. So that's going to be an ischemic time of 183 hours or so, 3 to 4 hours. So still way too long to seriously impact care. The medications given acutely are pretty good in terms of aspirin and P2Y12 inhibitors, and spotty on some of the other things. The discharge medications are pretty good for all comers. So I think again, if you come into a PCI center, you get pretty good care. And same thing for discharge interventions, exercise, counseling, dietary modification, and so forth. For NSTEMI, the age is a little higher, and the female sex is a little higher as well. You can see the rest of the parameters. Only 20% have ST depression or so, and 2% have ST elevation. So the rest of them have enzymes and so forth. Cardiogenic shock's very low. The mortality rate is still non-trivial. It's about 4%, which is where it's been through the years. So We really haven't made many inroads in the in-STEMI either. Cardiogenic shock is pretty low. The acute medications are about the same as STEMI. Thank you, Tim. As you can see, with the exception that P2Y12 inhibitors are not given acutely very frequently, cardiac invasive procedures are also not as widely utilized as we would have imagined would be necessary in this population, and certainly goes against guidelines. P2Y12 inhibitors really strikes me as not being at target in terms of the guidelines. As you probably know, people within STEMIs, irrespective of whether they get a PCI or not, should be discharged on a P2Y12 inhibitor, Plavix, ticagrelor, etc. And that's not happening about a quarter of the time. So I think people aren't up to speed on the current guidelines for in-STEMI treatment, which would be another topic this committee might want to deal with on the website, Catherine, is to get the in-STEMI guidelines out there and highlight the updates. I think that would be a good thing to do.
Okay.
So Dr. Cooley and you can collaborate on that effort. Revascularization strategies, you can see that 53% are medically managed, and I'm not really sure what that means, because these patients, are different. They could have a hypertensive crisis with ventricular hypertrophy, have an enzyme leak, and not really need revascularization. So I think that will have to be drilled down further. Discharge interventions are about the same, with a little lower percentage going to cardiac rehab. Baseline characteristics, as we mentioned, mean age is a little higher in STEMI. Female sex is a little more frequent. Diabetes much more frequent. Prior infarction much more frequent. Prior heart failure much more frequent. Prior PCI a little higher, and so forth. So you can imagine that this is potentially a sicker population, and the fact that the mortality is staying about 4% probably reflects that. The first evaluation, STEMI versus in-STEMI, it's in the emergency room in the majority of cases. And I really didn't know what that meant. I mean, how do you identify them as a STEMI in the cath lab? I'm not sure what that means. You guys, anybody have an idea about that? Tim?
Well, if they bypass, if they come in pre-notified and they bypass the ED, then that, by the action registry, his first evaluation is in the cath lab.
So even though if they have
that's a good
pre-hospital ECG, they don't have a slot for pre-hospital identification of STEMI?
Depends on how the abstractor puts it in, too.
Right. I don't believe so. I think this is at the hospital, where their first point of care is at the hospital. It's either in the ED, in the hospital floor, or in the cath lab.
Yeah, I think if anybody's brought in to us by an agency, we have a pre-hospital ECG, so whether it's private or not. So.
No, that's true, but then that would be listed by the abstractor as location of first evaluation cath lab. There's not a pre-hospital one on here, but they're just differentiating whether they were seen and evaluated in the ED or not.
That would be nice to know. Okay. And this is, we've already sort of gone over this. Similar, more hypotension in the STEMI patients, as you would sort of imagine. In my experience, the in-STEMI patients tend to be more hypertensive. So cardiogenic shock also more frequent, as you'd expect. Mortality rate, we've talked about that. It's double for a STEMI. Our reinfarction rates are similar. Heart failure rates are similar. Cardiogenic shock, quadruple or double in the STEMI patients. So,
one point about the mortality,
yeah,
that oftentimes we're stuck comparing apples and oranges. This is in-hospital mortality is what Action reports. And, of course, that can be very different from even 30-day mortality and certainly one-year mortality. So the STEMIs always look worse in the very early times, but, of course, the non-STEMIs tend to catch up.
Any comments on this, Robert?
Yeah, just to pick up the mortality comment that Tim made, is that this data doesn't capture the mortality from heart attack, STEMI or non-STEMI, that happens before patients even reach the hospital. You know, and that's a population, if we're looking at heart disease in Texas, that's all, I don't know how to get at that number. I don't know if it's even an important number, but maybe, I don't know.
I don't know either.
I have
That would be your reason to capture.
I have another comment in that there's 16% of the hospitals that are not represented in the Action Registry. Do we have any data to suggest, if we're sort of an overview of quality of heart attack or heart care in Texas, do we have is there a way to get at the quality of the patients that are represented in that hospital, those hospitals, and that what is the percentage of the total heart attacks that happen in Texas that are represented in hospitals that are not a part of that Action Registry?
Maybe Dishes can help us with that. Do you know? I mean, you're the database guy. You should know this.
Well, that's real good. Just throw it right back at me. Okay. These are just fleeting thoughts, Richard. I mean, I don't think that I'm coming to you as the wizard to think. I'm just throwing this out. And the other thing about the non-STEMI, the different types of non-STEMI, we all know in our clinical practice, it's such a can of worms, these non-STEMIs from, Tim gets a consult of a non-STEMI who basically is a dialysis patient who came in with a pneumonia, has a troponin bump.
Right.
That may explain your low clopidogrel use, but also I don't know if we tease that out. I mean, we're going to obviously not do a whole lot with that patient I mentioned, but really we want to focus on the non-STEMIs who have disease that we need to identify correctly, treat at appropriate times with appropriate medications. I don't know where to get at that information either. More questions than answers today from me, Richard.
We've been promised for years that ICD-10 was going to solve that dilemma, and I guess we'll see.
Any comments from this side? You guys are sitting there. Christine?
Taking it on.
No?
No comments.
But you're a consultant. You should know these things, you know?
I think my concern with the data, same as what's been voiced, is that this is a small set of data coming from some hospitals who are really working hard at it. So it would be interesting to see what the big picture for both STEMI and non-STEMI. I think it's awesome we're including non-STEMI because we haven't for many years, and finally we're realizing a non-STEMI is a heart attack too. We need to address that. We need this kind of data, and we need more data, but the big picture would be nice to know how in Texas, how everyone fares, no matter which hospital they go to.
Yeah, I may have missed it. That data was from all the hospitals in Texas that participate, or of those 50 that are contributing?
No,
data?
this is from national. This is a national data.
So that's
it's
1,000
1,000 patients nationally.
So this
1,005 specifically.
This is national who participate in
Action.
the Premier Get With the Guideline program.
I'm not sure.
Only the one report was Premier. So the rest was nationally who participate.
which really should be a large proportion of Texas. It was 116. How many did you say? 136 out of 150, and those are probably the biggest ones, I would imagine, too. So I would guess that was 80 to 90% at least.
Well, it's 85%. But is there a sense that there's better participation in Texas than nationally? I mean, the national data are distinctly different from the action data. I mean, you only 70,000 in action of STEMIs, and nationally it's 500,000, apparently. So what's the disconnect? Anybody have an idea? So it's important, because when you look at action, everybody's doing pretty well. But if you look at the CDC data, we're not doing very well.
So we know relatively what our participation rate in action is in Texas. Do we know what it is nationally?
That's what I ask.
Yeah.
Does anybody know?
Look at that map, right?
And
I don't think it's nearly that high. It's not 90%.
what would also be helpful is to be able to know how Texas compares to the national. So being able, so one of the things that's missing from the statistics is the statistics part of it, right? The standard deviations and confidence intervals to know is the 3% difference in mortality, is that real, or is that just statistical noise?
Good questions.
Just basic knowledge of how many hospitals are in the state, how many are PCI centers, and then how many are participating would help us maybe answer some of the other questions we brought up earlier.
So Robert and Tim and David have been most vociferous. Can you guys synthesize your questions and then forward them to Lonnie with a copy to the rest of us, and see if she can get the information?
Okay.
So, any other comments about that? Nobody wants to say anything.
So with some other conversations too about moving the door to balloon to less than 90 minutes. I mean, I've heard rumors of 60 minutes. Do we know how we stand on that, meeting that 60-minute goal of percent?
I don't. Another question, Robert. David, you. Okay. Well, now let's sort of drill down on what we're finding out from our cardiac investigation through dishes. So you've got your presentation. I teed it up. You guys want to introduce yourselves, and you're obviously not Neil, so.
Good afternoon. My name is Carla Granado, and I'm the project coordinator for Rider 97. I'm going to do a quick program update, and then I'll pass it over to Aaron to do the data presentation.
Great.
So in terms of hospital communication, we continue to expand the reach of hospital systems participating in the data collection project. We currently have 55 hospitals that have submitted their forms to provide access to the heart attack data. And we have 47 for the stroke data. We're working in conjunction with the American Heart Association to host a conference for participating hospitals and potentially those interested in participating. The conference name is Heart Attack and Stroke Systems of Care Summit, a focus on quality improvement through the Texas Heart Attack and Stroke Data Collection Initiative. And that will be held on July 24th here in Austin. We're currently finalizing the agenda for that. And in terms of data, our second analysis of hospital data is complete. The stroke and heart attack hospital performance measure reports have been uploaded to the Texas Heart Disease and Stroke Program website, and that can be found under the Council Projects tab. The link to these reports has been shared with stakeholders, including Rider 97 data consultants, the American Heart Association, hospitals, the RACs, GTAC, and the CVD Council. So now I'll pass it over to Aaron from the Office of Surveillance, Evaluation, and Research to present.
Before you get to that, when we heard the data presentation in February, or maybe it was November, there was concern because basically the only hospitals participating were in the greater Dallas area for the most part. Can you give us an idea where that spread to? If the other hospitals, or where are the other hospitals participating?
I know in the data that we're presenting right now, about 7 of the hospitals are from the Dallas area. I'm not sure where the rest of them are, but I know they're mostly in urban areas. There's only about 3 in rural areas.
It would be helpful for us to all know who's participating and who's not participating that are in action. So we could go back to our local people and stimulate them. I stimulated our system vigorously about 4 months ago, and it would be nice. I haven't heard if they came across and said, okay, the medical director of the hospital system said, sure, it's fine with us to participate. And whether that trigger got pulled, I don't know. Can you let us know
Mhm.
which hospitals are participating and which haven't signed the agreement and so forth?
I'm not sure that we're keeping the identity confidential right now of the hospitals, but we can kind of give a general idea of where they are across Texas.
Well, if we specifically ask if our hospitals are participating, can you do that?
Yes.
So the Memorial Hermann system?
We are.
You're participating?
We are participating.
St. David's participating?
I don't think so.
Huh? Don't think so?
Do we know what the barriers are for hospitals to sign up?
A lot of it has to do with just the approval process. Some of the hospitals don't have a current contract for the action registry, so they have to go through the contract process and get it approved by the CEO and leadership and corporate leadership as well. So,
Governmental distrust, suspicion. I think that's a big one.
Dr. Smallman, the Waco facilities both are in.
Yeah.
They're non-urban area. I know they both are. Temple.
Perfect.
Mason already said that.
I don't know if I'm urban.
203.
Can you give us that information by region, like by RAC?
How many hospitals are participating? Yeah, I
Yeah,
think we can do that.
One of our challenges is that in working with the hospitals and getting these data use agreements signed, that we've committed to not releasing their identity. So we're trying to figure out the best way, and part of this will come with additional participation, but how to really regionalize the data so we get a better picture of, data across the state.
Well, Dr. Rodriguez sent me an email saying, can you please get your hospital to participate? So, and I did. So I thought I did it, but I'm not sure I was successful or not. So there is a way, obviously. Right.
Yeah, we can work with you individually.
Perfect. Yeah. Go ahead. Go ahead. Thank you.
All right, I'm Erin Wu. I'm an epidemiologist with the Office of Surveillance Evaluation and Research at DSHS. I'm going to just start with some background for those of you who aren't entirely familiar with this project. So during the 83rd Texas legislative session, funds were appropriated to advance heart attack and stroke reduction efforts throughout Texas. To inform such efforts, the Texas Council on Cardiovascular Disease and Stroke has launched a heart attack and stroke data collection initiative. The data collection initiative focuses on pre-hospital and hospital data elements, and this data includes de-identified aggregate data for hospitals who have agreed to share their action registry, Get With the Guidelines, and Get With the Guidelines stroke data with DSHS. All data is protected under HIPAA guidelines, and the aggregated data is intended to inform stakeholders about opportunities for collaboration and system enhancement. The objective of the data collection initiative is to gain an understanding of the prevalence of heart attack and stroke in Texas, evaluate pre-hospital components of the systems of care, and treatment of heart attack and stroke patients. The findings will be used to assess policies and practices regarding delivery of care across the state and identify areas of opportunity for quality improvement while recognizing achievement among hospitals. The data were collected by the Action Registry and reflect hospital care from October of 2008 through September of 2014 from 47 participating hospitals. So 47 is what I'm reporting on today, but we have a few more that have joined since this report came out. Of those hospitals, they're distributed across 30 cities, and as we mentioned earlier, the majority of the participating hospitals are located in urban or suburban communities, 8 of which are located in Dallas, and 3 are located in rural communities. The data were analyzed for reporting, quality, and achievement measures for effective care for heart attack patients. These measures listed on the slide were selected through collaboration with the Rider 97 data consultants. The ones indicated by an asterisk were added after the first report was published based on feedback from the data consultants. Between 2008 and 2014, 29,849 cases of heart attack were reported among 28,759 patients. And that's by those 47 hospitals that are participating. Of the episodes of care for heart attack that occurred, 33.3% involved care for STEMI heart attacks. Nearly 60% involved patients who either transported themselves or were transported by family to the hospital where they first were evaluated. And 77% involved patients receiving their first ECG upon arrival at the hospital. The national standards for hospital ECG performance time is within 10 minutes of arrival. Transfers and direct presenters are displayed here by mode of arrival to the first hospital. 38% of eligible patients who arrived by ambulance and directly presented to the hospital, to the reporting hospital, did not receive an ECG within 10 minutes of arrival. And among patients that arrived to a STEMI referral hospital by ambulance, 38% did not receive an ECG within 10 minutes of arrival at the referral hospital. The median time spent awaiting transfer from a STEMI referral hospital to a STEMI receiving hospital for PCI was 41 minutes among those who arrived by personal vehicle and was 48 minutes among those who arrived by ambulance. Directly admitted patients and transfer patients are displayed here by mode of arrival to the first hospital. Among patients who arrived at a STEMI referral hospital by ambulance and were then transferred to a STEMI receiving hospital, the median ED dwell time at the receiving hospital is 51 minutes. For the measure related to door to needle time within 30 minutes, here we have patients who arrived to the first hospital by ambulance. Nearly 32% received fibrinolytic therapy within 30 minutes of arrival. The standard of care for time from hospital arrival to PCI or device activation, commonly referred to as door to balloon time, is 90 minutes, as mentioned earlier in the earlier presentation. Among directly presenting patients to a STEMI receiving hospital, the median time from arrival to primary PCI was 67 minutes. And that's among those who arrived by personal vehicle, and it was 52 minutes for those who arrived by ambulance. And related to the previous measure on door to balloon time among directly admitted patients, among those who arrived by ambulance, nearly 98% received primary PCI within 90 minutes of arrival, and then just over 90% of those arriving by personal vehicle received primary PCI within 90 minutes. This is the measure for door to balloon time for transfer patients. And we're looking at time within 120 minutes of arrival. So among patients who arrived at a STEMI referral hospital by personal vehicle, about 70% received primary PCI at the receiving hospital within 120 minutes of arrival at that first hospital. And that's all.
So based on these data, are there any plans for interventions? I don't think it's up to us, but I just want to hear it from them.
I think so. The idea with this data is to be able to provide it to the stakeholders and provide these reports to the hospitals that are participating as well, so that they can try and focus on different elements and time measures that they can improve on. So.
One of the things I mentioned yesterday in the stroke committee, as I did a presentation similar, is I think it's really important, especially when you're looking at some of these measures. I would like to know what we were in 2008 and see where we are in 2014, because I would expect to see ED dwell times significantly decrease because our awareness has come a lot in the last 6 years. So it would be really good for us to have this report trended quarterly, maybe by year, and also how many participating sites have data within those quarters or that year. So I think that would help give a truer picture of where we're at with this data.
I think one of the other things about this that we brought up a minute ago is at least reporting this in sort of a regional or metropolitan regional area to look at this a little better, because some of this data is honestly a little counterintuitive. about the private vehicle patients seeming to have better times and stuff. So my assumption is that there's probably outliers in both directions based on the facilities that are reporting, and it's difficult for me because we, in our region, we know what our collected data is, and it contradicts some of this. So either something's wrong in our assessment, or maybe our data is congruent when we see the state breakdown. It'd be nice to know where those because we're getting to the point where it's taking more and more effort to make smaller and smaller gains in some systems, where in other systems it's probably huge gains relatively easily, and figuring out where that is would help a lot.
I think Dr. Cooley makes a good point about if you reflect on the progress that's been made in your own STEMI systems of care, there's a certain level of competition that was motivational, say, between different hospital entities. And so if this is just one big collection of data, if it's broken down even geographically, there's a certain amount that may be motivational in some respects to say, I remember in my days when we were building our STEMI system, was sort of like, come on, you guys in the northern part of town, or, how come the southern part of town seems to do so much better? And so that was motivational, and it seems like it got things done. So I don't know if that's where you're going with that. That may be a use for you. And the fact that there's 45 hospitals, and I know Texas has a bunch more, and I know that's probably something that if you've talked about plans, what do you want to get happen? I say like get more data, and so it's.
So one of the things that clearly stands out to me from this data set is that, so maybe not necessarily if you're close enough to drive directly to a receiving facility, but if you have a choice to drive 5 minutes to your non-PCI center or 45 minutes to your PCI center, it seems like calling EMS is the right thing to do, because they know where to take you once they diagnose the STEMI. So that may be one of the efforts is to, for public awareness, if you're having chest pain, to call 911. Don't drive yourself to your local facility because that may not be the right place to go.
And we can do it in a blinded fashion, do Texas, and then do all the racks put a number for each rack, and only that rack would know what their number is. But at least then we can look at rack data, state data, and our rack, we've been able to do stuff like that with our hospitals, and it does create some friendly competition. They do want to make their numbers look better. So you can do it in a blinded fashion because I know you're sensitive about sharing the data, but I think it's information that we could all take back to our racks and make the system better.
I had one other question. When I look at data like this, a couple things I try to look at is try to grab the low-lying fruit, identify it, and choose and do something to have an intervention. The other part of the data I look at is something that's shocking, that will be almost appalling. So I don't know if this logic is correct, but if 60% of the people come to these 45 hospitals via private auto, they said their first EKG is obtained in 77% of the time in the hospital. So I'm thinking, well, that means 60% is private auto. They wouldn't have an EKG until they got to the hospital, but 40% would have been by EMS if you think. So does that mean 17% of the people that are transported in that population by EMS don't get a pre-hospital EKG? I don't know if that's true or not.
That's what's missing, I think, in this data is of the 38% overall where the EKG was not done within 10 minutes, what percent of those patients had a pre-hospital EKG that clearly says STEMI written all over it?
Well, the other part of that is we still have a lot of ambulances that don't have 12 leads. So they wouldn't have been able to. Well,
that's what I'm saying. That when you get data like this, where's the shocking part? And so it's not that identifying. I'm just saying getting an EKG, getting one, not identifying. So I'm saying 17% of the people that are transported in that population, they don't even get an EKG. I hope I'm not on that EMS wagon.
Well, maybe that's something we should add to this is pre-hospital ECG. We don't have pre-hospital.
Is that on the data set?
It's in the full report.
Okay.
Mm-hmm.
So do you have a sense of what that number is? That would be very helpful, because one of the things that we hope to be able to do in the coming biennium is to influence greater participation of EMS agencies which utilize 12 leads pre-hospital. So if there is a big gap there, we need to know about it, and we need to let other people know about it.
So
I
I
think
have a question for Carla. I am at the CBRAC, and I got the full report because I participate and I'm on that. So when you guys sent out that big, long, full report, I did open it and read it, and I was able to pull my data out and see what my RAC was doing, and I could also see what the state of Texas was doing. So in that full report, we are able to compare RACs against the state picture, correct? That's what I saw.
I believe you might be, are you referring to the regional report? Because there's hospital reports, and then there's a report using the data that was given to us from the RACs.
That's what I'm asking, I guess, because the report I saw, I was able to see my RAC as compared to the rest of Texas.
Yeah,
That's
that's the
not-
Mission
it's a different
Lifeline
data.
regional
Okay.
data. This is
Okay.
patient level data. That's not patient
That's-
level data.
Okay.
Yeah, that's just regional, most of the pre-hospital data.
This is out of the this is the ones that signed the contract
With-
with DSHS to get the action information.
Okay.
No. Did the members of the Cardiac Care Committee get the full report?
Yes, every time we post reports, we send out the link, and it's on the Texas Heart Disease and Stroke
So you didn't
program
send it to
website.
us? Did you send us the link, or
No, I believe I sent the link.
you sent the link? Okay.
We can send it again, though.
Yeah.
You know, many of us get about 200 emails a day, so sometimes it,
Yeah, but I never saw it.
you know, if you could send it to the full Cardiac Care Committee, that would be very helpful.
But I do think if we could somehow break out even this data by regions at least, because those of us that sit on our RAC cardiac committees would then at least kind of know. I mean, if in our RAC 77% of the patients weren't getting an EKG till they got to the hospital, well, I know how many EMS agencies can do 12 leads. So if 77% are not, that means there's a lot of people not doing 12 leads because they have the capability. So I think then we could regionally kind of maybe come back next time here and be able to say, here's what we were able to drill down regionally, but we'd have to know.
So is that a possibility?
Yeah, and I mean, that's our intent too. Again, it just kind of depends on participation, and what we might be able to do is kind of, if we can't drill down to RAC, if it's gonna, expose one hospital, then maybe we look at sort of a bigger geographical region to start, like maybe the DSHS Health Service regions or something, but yeah, that's our intent too. So we can absolutely look at that, in addition to the trend data.
Would it not be easier just to ask the hospitals, can they share the data down to the RAC level? I mean, we have that data already, I guess is what I'm saying.
Right.
In most of the RACs. I mean, it seems like there's a whole bunch of stuff going on in just one report. I mean, the by year really throws us off. In 2008, I would say there was probably 70 people. I agree with you. Yeah, I mean, that way throws this skew, and you can't compare it to your RAC because this is 47 hospitals across the state of Texas.
So I want to commend Carla and her team for the work they've done thus far. I'm Jennifer Gardner from RAC-E. When this project launched in June of 2014, it was until December of 2014 that I was able to identify which hospitals, entities in my own region actually had contracts with DSHS and with AHA, because that was not to be released. So I had to ask who did not have contracts, and then I could start to identify those. So I was flying blind for 6 months into this project, and going on good faith and goodwill. I wish that we could think forward and drive it down to the EMS agency and the hospital and identify their vendors. Because I know a lot of that problem comes from the fact that these data elements, which is a big problem we talked about yesterday in Stroke Committee, right? And their data elements and their documentation and their analytics don't support generation of these. And I want to identify those vendors as well. So keep that in mind when we drill down to, and also another thing that I've noticed here when we're starting to identify those contacts and those agencies and those facilities across the state of Texas, there's some incongruencies there, right? So we want to make sure we have that most up-to-date list of those facilities and agencies, and that we're also identifying the vendors. And that is a data element that is already currently aggregated.
Any other comments? So are you guys going to get back and visit amongst yourselves and then provide us some feedback? That would be very helpful because it's really a critical time, as you know, with the funding, potential funding of STEMI work, whatever that's going to be. And it would be helpful for us to drill down on things that we think would have the most bang for the buck, so to speak.
What's the plan in terms of, is this something that will be produced quarterly, or what's the cycle for this data?
We intend to continue to produce it quarterly. I mean, it's all dependent on, funding that's in the legislature's hands right now.
Right.
But our intent is to continue to produce it quarterly.
So, but this is multi-year data, is that right?
Right.
Okay, but you could produce it. You could just give us 2014 data or fourth quarter 2014 data or something like that. Yeah, I think it's a good point. 2008 was ancient history in terms of heart attack care, so probably looking at, whether quarterly, if we have enough data for that, or at least 6 to 12 month period, no more than that, because it's a rapidly changing field, I think.
Still open for comments?
Yeah.
I'm Dr. Drucker. I'm the manager of the Injury Epi Surveillance Branch for Department of State Health Services. So I just want to make it known to this committee, this is actually the first time I'm speaking here, but I've done a lot of work with Catherine. One of the programs I oversee is the EMS and Trauma Registry System, and I'm talking specifically about the pre-hospital component today. My registry collects all EMS runs in the state of Texas. Right now it's about 2.7 million EPCRs I get annually. And one thing that we're doing now is we're transitioning to the NEMSIS V3 version. Within the V3 version, there's about 116 data elements that are defined for a STEMI PMs. And so I had a similar conversation in the stroke committee with Dr. Rutledge. And one thing I offered Dr. Rutledge was to provide a committee with a listing of all the data elements that the NEMSIS data standard has identified for stroke. And so I can do that for the cardiac care committee, provide you all the data elements that my registry will be collecting that are relevant for STEMI. And right now, that's about 116 data elements.
Data elements just for STEMI. Is that just for STEMI?
Yeah. Correct.
And how will we have access to this? In a report?
Correct. And so I have a staff of 5 EPIs, and they present reports. They've been presenting reports all through these last couple of days. And so if the committee has a specific interest in specific data elements, after I provide it to you, we can easily run reports once we start collecting the data.
This would be awesome data to have, this data for our committee, for on the pre-hospital data points.
Correct. So about 2.7 million EPCRs, a little over half of them are medical. About a quarter of them are unknown. So there's quite a bit of data that my registry collects, and quite frankly, there's quite a bit of data in the medical aspect that we're not doing much with. And so I'm trying to get it out there. There's no point in collecting the data if you're not using it for improvement.
So I'm sorry, what was your name again?
Christopher Drucker.
Drucker?
Drucker. Dr. Drucker. So, if you want to contact me, 512-776-3575. That is my direct line.
What was that again?
776-3575. I've done a lot of communication with Catherine. So, Catherine, if you want to pass out my contact to the rest of the committee, please do so. We have a wealth of data that we could utilize for this committee. I've already talked with Katie, and we're going to be collaborating between her branch and my branch to see how we can augment their data needs.
So I think that last comment was what I was going to suggest, and that's probably the most important thing you just said, was that we have historically isolated these things as the pre-hospital data. I want the hospital data. And so, you know, this is a continuum of healthcare from the moment they call 911 or don't to the point when they are, you know, discharged even back into rehab and these kind of things. So if we need to try to stop thinking of these as discrete data sets, as this is the patient data continuum, and figuring out ways to, whenever possible, integrate the data, and most importantly, for those of us in the pre-hospital world, have that communication and data sharing go both ways. So the hospital systems and the state systems and everybody are very happy to suck the data from the EMS providers, who obviously, you know, there's NMSIS is what, 400, 600 data points total, depending on how you integrate it. That's a lot of clicking and things, and that's a lot of report generation that these crews and street providers have to put up with and do when they don't, and it's very frustrating on that level when they don't ever seem to get any of the data or the interest back, or they just want to find out something simple for a patient and they can't get that feedback from the hospital. So as we build all these systems and we build all these databases that are very important to try to help us figure out the healthcare of our citizens, we really have to find the ways, and from the legislative standpoint and the regulatory standpoint and the boots on the ground standpoint, to get this communication going both directions so that we can really help. Because that small agency that figures out that feedback they're getting from the patient that they sent that ended up 3 hospitals away or 100 miles away means a whole lot more than seeing some aggregate report of the health of the state.
So how many data elements again? 100 and what?
16. So specifically identified for STEMI based on the NMSIS, it's 116.
Wonderful. We have some people that are very interested in helping with this, so statewide. So we'll be in touch.
Will do. Thank you.
Is your database, is that all just pre-hospital, or does that also capture some of the inter-facility transfer data sets?
It captures all EMS runs. So 911, inter-facility, transports, all of them come to my registry.
To Dr. Cooley's point, though, I think this highlights some of the gaps in the data, because the data that the hospitals submit to the state registry are only trauma runs. EMS submits all runs, so we can get their STEMI data, but there's nothing to marry it up with from the hospital standpoint. So then we're going to take that data and then try to marry it up with this data, which is obviously incomplete. So I mean, the struggle is still going to be there. I think it's a good place to start. I can't wait till January of next year, because Mr. Schmieder's office will then do away with the waivers. So people that are still on paper records, that are just in good faith saying, you know, I can't submit to the registry, will now have to submit their data, because I know in our region, a lot of the rural providers are still on paper records, so we don't have their data today, even if he were to run us a report. And those are the ones that I think are lacking the 12 EDKG assistance that we need to look at providing. And so there's still a lot of holes in the data. And I applaud the work of Mr. Drucker's group, but we're still not seeing the whole picture. Dr. Drucker's group. But yeah, we need to find a way to start marrying all these different reports together so we really know what's going on.
So this is very exciting. Thank you very much.
So just one last note, talk about the marrying of the data. Something that we're able to do on our registry is link all of our data. So we've linked the crash records we get from TxDOT to EMS records to our hospital records. So we have the continuity of care. So just an idea, maybe us at DSHS could talk about if this is a possibility, depending on the data that we get, if we had the sufficient data elements in there, so we can see the continuity of care from an EMS transport to a patient being dropped off for care. So, thank you.
Thank you. All right. So several times ago, we were tasked or asked to help revise the strategic plan for the Texas EMS trauma system, and this was a 2002 document, and toward that end, 2 committees were formed to attempt to add cardiac information to that. In the interim, the Dr. Brian Eastridge, a trauma surgeon in San Antonio, actually rewrote the document and just distributed it to some of us, which looks much more organized and better thought out, not to detract from the original document, but I think things have evolved so dramatically that we have the opportunity to make it a more pertinent document to the emergency care as it exists today. So, Dr. Cooley, you want to talk about your guys' results, folks' results, I should say?
So to be honest, I think, like I said, Dr. Easters did, I think, a wonderful job of kind of rewriting and broadening kind of the goals we were looking for, and spending. So in a sense, we spent a little time on something that maybe ultimately won't come to direct fruition from the original document, but certainly there was some feedback and there's some editing things that that were looked at. But I would actually recommend that, if anything, I know they're wanting to look at this even, I think, tomorrow at GTAC, to email this out among ourselves tonight, try to take a quick look at it. If there's any specific things or things that jump out, get those back to probably Dr. Smalley that we can forward on for tomorrow's committee.
Well, I think it's a little premature to forward on much at this point. I think we have to look at the document which just came out in the last week and think about it a bit, given the information you already generated. David, you've generated some work as well toward this end. Did you look at that document?
I've given it a cursory overlook, and I mean, I just back up what Dr. Kula said. It's a much improved document, and I think there's a couple of points we can add in there, but I don't have anything to add into it right now.
So Richard, could I ask, since it sounds like we may not have any finished product, but do you mind spending 5 minutes to talk about conceptually, philosophically, some of the thoughts that you have, and anybody else can share thoughts on what's the goal in terms of, or what sort of the points that you want to make sure that are represented in that document?
Well, I think it's an informational document, probably directed at least in part to the legislators, to say here's what emergency care looks like in Texas today. And toward that end, Dr. Eastridge's volley going out was that there would be some demographic maps of Texas as to what the mortality rates for each disease entity, STEMI being first, stroke second, and injury third, geographically in Texas. And as you know, East Texas for STEMI is lagging behind many of the areas of the rest of the state, but I think it would be informative. I think the information needs to be included that what percentage of runs are STEMI, or medical STEMI, medical stroke, medical pediatric, for instance, and injury/trauma. So these are, I think, the sort of the basics behind it. But the important thing is, what does it look like, and where are the gaps, and what do we need to do to close those gaps?
So again, I'm reading the document. It's a very detailed. I mean, I credit them, and it's almost prophetic. You know, some of the stuff that they were coming up with and talking about integration of pre-hospital. You know, back in 2002. So I'm saying, from our committee, looking at this as what are certain things that we would like to make sure are represented? You know, is there anything else that you feel in reading that was missing, or do you want to make sure they drill home the 12-lead EKG teaching, or anything in particular?
I think all of it.
Yeah. So, yeah. I was impressed by it was fairly detailed, and again, I thought it was well written. the one from 2002.
Yeah, no, true, but it's evolved.
Right.
And
Oh,
so,
sure.
Yeah.
So is there value then in kind of re-upping the committees and circulating the updated version of Dr. Eastridge for review to push that?
Well, so then I think from my perspective, I've looked at it twice, but again, somewhat cursorily, and haven't gone page by page by page and then compared it to the prior document, page by page by page, and what you guys have revised. So I think it would, and I hate to say this, but I think we need to look at both sets of documents, and everybody on the committee ought to weigh in on how much should we include all the stuff that you guys came up with recently, or do we need some of it? Where should it go, and so forth? And it's the end of the year, end of the school year, blah blah blah, and so everybody's not in the mode to focus on it. But probably it would be nice to focus on this before the next meeting in August, I guess.
But I guess the document itself should have stuff that we've talked about for a while about maybe a common data set.
Exactly right. Exactly.
Appropriate funding, equipment, the stuff that's our mantra almost. So,
right.
Again, those are certain things that I think from this committee, if anybody wants to brainstorm, make sure that's those 6 things in it.
Sounds like you have a new committee member.
Well, he's an old committee member.
He's an old
No, but I'm just saying that we don't have the document. We're not going to rubber stamp anything here, but I think that philosophically we could all agree that these are certain points that we want to make: data, equipment, funding.
Well, what I'll do, I don't have the technology, I think, to circulate this today, but over the weekend at some point I'll send it out to the whole committee, what I was sent the other day. And then you guys can weigh in. I think you in particular, if you've got the ability to focus and drill down on the various areas, could send out a quick synopsis of what you think you ought to do, and then everybody else can weigh in. I think that's perfectly reasonable.
Dr. Eastridge had mentioned that he would do some appendices for it. So if we wanted to do something specific for cardiac.
Well, there's sections that are cardiac.
Yeah.
So.
If we wanted to get that detail.
Well, but we have to get some detail. I mean, the important thing is how many people get ECGs in the field? Not many. That's been correlated with improved outcomes. Big gap in Texas. Okay, et cetera, et cetera. I mean, Robert's sort of hit the nail on the head, I think, is focus on the gap analysis and what should be the optimum. I mean, what should the mortality be? Shouldn't be 10%. As we've said all along, it could be less than 3% in hospital mortality if we got our act together. So that's a huge, huge, unprecedented decline in mortality. All right, so we'll have to rethink timelines and so forth. Maybe you guys could send me an email and see what you think after you look at both things. Okay. Dr. Mixon, you're next on the agenda.
Okay, I'm going to give an update on the Toronto Heart Attack Collaborative.
In a Canadian accent,
I guess someone searched for that on the internet, and that's what they came up with. This is actually the Texas Heart Attack Coalition, not nearly as famous as the Toronto Heart Attack Collaborative. So the Texas Heart Attack Coalition, many of you are familiar with what that is. It's really just a volunteer group of interested stakeholders. We've been meeting by conference call over the last 12 months, maybe 1 or 2 in-person meetings, just with the goal of trying to improve heart attack care, trying to bring multiple groups together, individuals. Many of the participants are just individuals from various systems, but we have tried to attract and involve various organizations that may have some dog in the fight, so to speak. So American Heart Association and American College of Cardiology, Texas Medical Association, Texas Hospital Association, basically anybody that might play a role we've wanted to involve so that we could hear their ideas, so that we could advance ideas that we could all agree upon. One of the goals, but not the exclusive goal, was the thought of should there be legislation in the state of Texas? How do we need that? How do we promote that? I think basically through the discussions, there's a lot of difference of opinions, of course. We didn't feel that that was absolutely necessary, but it could be useful in some situations. I think everybody agreed that funding would be desirable, and so that was a group that could begin to formulate some goals and pursue that. Essentially, but we are not a lobbying group. We are not a official nonprofit organization, really just trying to kind of hear and create a consensus and give some priorities. And essentially, we came up with 4 priorities, which are, again, similar to what we also, as the GTAC committee, Acute Care Committee, have discussed, and that surrounds issues of data collection, both pre-hospital and in-hospital, much of which is being done, but we certainly see ways that we can enhance data collection. Education is a second priority. Funding for the RACs, and specifically funding to help provide for cardiac and stroke care, which has been lacking. We felt like that was an important piece because the RACs really are an essential structure in the state in terms of improving care on a regional level. And then the issue of pre-hospital equipment and training and how to use that. So those were the 4 priorities. We did have some conversations with various legislators about funding, and really much of that's been done in a piecemeal fashion. Various groups were championing certain causes, and that made sense for them to continue to do that. So a lot going on right now in terms of legislative type work and funding type work, of all of which we'll know soon what really becomes out of that. So I think it'll be an ongoing conversation. Again, many people in this room are involved, and we appreciate people's input and their participation. And our belief is that the more we work as a team, the more we involve different stakeholders, that really is a path to improving care in our state.
It was an important exercise to get on the table the anxieties of all the stakeholders, and by vetting that process through some somewhat intense interactions, I think people became comfortable with the thought that the sweet spot for STEMI care in Texas, given the good performance of the STEMI PCI centers at the present time, would be the pre-hospital phase, and that's where we need to focus our actions. And so all the stakeholders that Tim had mentioned agreed, and rather than fighting the idea of focusing on STEMI, that they seem to embrace it. So I think we made some headway, and there's a lot more to do, but at least people are talking and are pulling in the same direction. So, Robert, do you have anything else to comment on that effort? All right. Well, is there any other business? Any other public comments?
I'll just say my group has put on a statewide STEMI meeting, STEMI Texas. This will be our 8th annual meeting. We are going to be doing that again this year. It's going to be in Dallas this year on October 29th and 30th. So you can wear a Halloween outfit if you want. It'll be right before Halloween. That'll be fun. So there'll be more details. We're actually going to broaden the focus a little bit to try to bring in folks from other states. it's been very fruitful, obviously, to learn from each other and learn from different regions and spur each other on. And we think that we have a lot to offer as leaders from the state of Texas outside the state, but also a lot to learn. So that'll be exciting, and there'll be more details to come, but you can be looking for that October 29th and 30th.
Catherine, do you want to mention the Accelerator 2 project?
I would. So Houston is a part of the Accelerator 2 project. For those of you who know what the Accelerator 1 project, it was the Duke Clinical Research partnered with the American Heart Association for 14 areas around the country to look at STEMI data, using action registry data. And the purpose was to identify the gaps that we had within our care, looking at pre-hospital through hospital data elements. The project was unfunded, so basically the areas that were chosen had to have the infrastructure in place, and it was very successful to help those areas really identify gaps in care. They've come to second phase of it. We received some funding, I'm not sure how much, but one of the things that we're going to do is we're going to expand the EMS data elements, and we're also going to integrate more non-PCI hospitals with the second phase of the project. So more to come at future cardiac committee meetings.
Excellent. There were any other sites in Texas?
Not that I'm aware of.
How about that? All right, we got 10 minutes left. Anybody have a joke? No, seriously. I think everybody would be happy to end early. Any other comments? Yeah.
We're used to beating the clock.
Yeah, we are.
Right.
All right. Well, thanks for coming, everybody. Appreciate it. Excellent work.
It's our expertise.
We're adjourned.
I probably didn't make that clear. That was kind of how I was thinking on that, so I'm sorry.
Yeah. I hadn't.